Most of the evidence that we have as psychiatrists come from Western countries. That means that it's culturally biased. That means that if an intervention is not aligned with the culture of where this intervention will be provided, people might not feel it relevant. They might not be willing to receive it or to be part of it or to implement it. Before implementing any intervention, before doing any research, we really need to first make sure that the intervention that we want to test or provide, it's aligned with the social and cultural values and context where it will be taking place.
A very warm welcome to the Flourishing Minds podcast. I'm your host, Chris Underhill, and today we have a wonderful conversation for you. This is with Dr. Irene Falgas Bague, who is a clinical psychiatrist and public health researcher and a project leader at the Department of Epidemiology, I have to get that one right, and public health from the Swiss Tropical and Public Health Institute. And normally the Swiss Tropical and Public Health Institute is referred to these days as Swiss TPH. So Irene, a warm welcome to you. Lovely to have you with us on the podcast today.
Thank you very much, Chris. It's an honor to be interviewed and to have this conversation with you.
It's super. And believe you me, the honor is ours. So look, I wanted to suggest that we go straight to some of the exciting work that you're doing with your Zambian colleagues in Zambia. And I know that you're working in two different fields. You're working with women and their well-being, and you're also working on suicide and suicidality, suicide prevention. Why don't you jump in and tell us about some of the work that you're doing there?
Yes, of course. We started around 3 years ago. The Swiss Tropical and Public Health Institute is an institute that has many partners around the world and doing research. But there was not such a research in mental health yet at this point. And what we did is we started creating evidence and creating data. There was a cohort of women and their small children under 2 years old. And it was part of a project based on related on nutrition. So what we did is to analyze this data. It was involving 2,400 women.
Wow.
And we wanted to see, and it was a representative sample across all the country of Zambia. And we wanted to see what were the levels of mental distress among this group of population that, as you can imagine, has a big impact, not only for themselves and their capacity to enjoy and to live their life, but also on the children and future generations. So what we saw is actually that around 28%, 30%, and even higher in specific subgroup of women were exposed to mental distress. And that was the beginning of our work in Zambia. So it actually came from a nutrition project that we were able to see that this was a group of population under a big stress.
Right. So this was a very practical demand in a sense, wasn't it?
Exactly. Yeah, this was a demand that came from the group working with nutrition and child development research, and I kind of chimed in or entered in their field to look at the mental health of this population. And that, it brought us, it's not enough to only bring the evidence, although it's the first step and completely necessary. But I come from a clinical background, as you said, and that brought us to co-develop an intervention. So we looked for partners first in Lusaka, in the capital of Zambia, and we looked for who could be the people who are the experts in the field, in the context that we wanted to do research on. And that's how we started our collaboration with Dr. Paul, the chief of the Department of Psychiatry at the University teaching hospital in Lusaka in the Department of Psychiatry at the University of Zambia.
Yeah.
And he introduced us to all the team there. And together we co-developed an intervention that would fit the specific needs of women living in Zambia with the small children. And that's how we developed an intervention that it's called the Problem Management Plus for Moms. And this is an intervention that it's adapted, culturally adapted to that specific settings. And it comes from an evidence-based intervention that was developed by WHO, the Problem Management Plus.
Great. That sounds really exciting.
It is.
It is exciting, exactly. And I know that at some point you might share with us that you have actually been able to accrue that evidence into some important research. But just take a step back for a minute. You were talking about culturally appropriate. Now, what do you mean by that? What particularly was meant by that when you sat with your Zambian colleagues and designed the intervention?
Yeah, this is a super important question, I think, for the current state of global mental health and mental health that it's practiced worldwide, I would say. Most of the evidence that we have as psychiatrists and as global mental health or mental health researchers come from Western countries. And that means that it's culturally biased. It comes from the culture of the Western world. And this is something that has implications for many things, from efficacy to engagement. That means that if an intervention is not aligned with the culture of where this intervention will be provided, people might not feel it relevant. They might not be willing to receive it or to be part of it or to implement it. So it has implications at all levels. We need first, before implementing any intervention, before doing any research, we really need to first make sure that the intervention that we want to test or provide, it's aligned with the social and cultural values and context where it will be taking place. And this is extremely important, and everyone thinks it's completely natural. However, it's not, always done. So that's when I say culturally appropriate, is that it goes through a very systematic process of adaptation to the context where it will be provided. And this adaptation, it's a process that needs to be done in a systematic way. So we don't lose the core components, what we know that is actually making it effective, but we adapt it in a way that actually people from the context where it will be provided feel it completely theirs and align on their values.
Right. That's quite difficult, isn't it? When I think about it, I mean, it's or to put it another way, it's often not done, and therefore you get this bias coming in. Exactly. Are you able to give examples that as to how that was actually done in practice in your particular case, in the case of your colleagues in Zambia?
Yeah, I agree. This is not, something that you do automatically. It requires some training, and I was fortunate to have experience before and do that before for other communities. This is not something you can do as one person project. I could not have done that alone at all. And as you can imagine, I'm not an expert in Zambia cultural values. So this is only possible when you partner with people who really know the context, who are embedded in this context, and can really speak all languages in the sense of the scientific language, what is evidence-based research coming from a Western world, and what is clinical practice, and what is mental health looks like in their setting, in our case, Zambia. So I actually did that with Dr. Tandiwa Tembo, who's a psychiatrist in Zambia, and together we're kind of leading the process of adaptation. But that process involved first reading everything that has been read in terms of anthropology-based studies on what is mental suffering in Zambia, in Southern African countries. So to read about it and have the literature, but then also to create focus groups, like groups with women with small children living in Zambia who could give us their perspective. Right. What were their main sufferings? What were the reasons for their mental distress? What did they understand by mental distress? Right. What were the words that they used to describe mental distress? Right. What were their wording? And that all this was a process of several in-depth interviews we had with women one-to-one, but also in groups, so we could actually capture the social part of it and how this wording gets communicated. So that was just the first step, and then we did a first round of adaptation of the original manual, and then we showed this manual to the same people that were helping us with the adaptation. Oh. Yeah, and so it's a stepped process, yes. And it's something that it's kind of a formal framework of cultural adaptation of evidence-based interventions.
That sounds really fascinating. Thank you, Irene, for that quite deep explanation, which is really useful. Now I understand what has come about as a result of that work.
Yes. So actually, this is an intervention that comes from WHO, the Problem Management Plus. It's usually originally 5 sessions. Now we converted because of this adaptation to a 10 session. And this is rather intensive for global mental health research. It's 10 sessions of psychotherapy, 1 hour long. It can be provided in person or by phone. And when it's provided in person, it's in women's homes. Mm-hmm. It's usually individually, but the first session and the last session are provided in groups. So it's pretty flexible. It's what we call a low barrier intervention. That mm-hmm. means that it really tries to tackle the main obstacles that the targeted population, in our case, women with small children, face to access mental health care, because this is one of my specific interests is on increasing access to mental health care in low-resourced populations. So basically, it's an intervention that can be provided in a very easy way.
Right. By who? Sorry, I'm sorry.
Exactly.
Provided by who? Who
this is exactly what I was about to say, that
right.
This accessibility goes not only to provide it by phone or in people's houses, but also because it's provided by non-clinician personnel. And that's, I think, a big also adaptation that we had to make in terms of training program for people from the community who had a special interest in mental health topics, and who wanted to be trained on providing psychotherapy.
Okay.
And that's what we did.
Is that a kind of task shifting effectively? Is that what you would call it?
Yeah, of course it is. The only thing is that in that case, the Problem Management Plus originally has been already thought to be provided by lay workers. And we already had it. But yes, it's part of the task shifting model because it's psychotherapy, it's evidence-based psychosocial intervention provided by a non-mental health professional.
Excellent. And do you think that will get embedded in the Zambian Ministry of Health, etc.? Because that would be a wonderful thing, wouldn't it?
Exactly. Of course, that's the goal, as you can imagine. That's our goal. to implement it through integration with the public system. First, you need to develop the intervention, and before saying this needs to be integrated, you need to know that this intervention is effective. We cannot jump on the steps of research and science. So the next step we did was to pilot it and to test it through a clinical trial design research. So that's what we did. We first did the clinical trial to see if the intervention provided that in this mode was actually effective to reduce mental health symptoms and to improve overall well-being of women. And we were also interested in seeing their relationship with their children. So these were our main outcomes for a clinical trial. And so that's the first thing we did after developing the intervention. And that took a little bit of time, as you can imagine. And now we can say, yes, the intervention is effective. Yes, it is ready now to be integrated into the public system. And we are right now in conversations with the Ministry of Health on how this implementation or this scaling of the intervention could look like in a setting with low resources for mental health.
Right, okay. Now, as a result of all that work, I know that you got into discussions with, because we talked about this earlier, you got into discussions with your colleagues in Zambia, and they introduced to you a second subject, am I right?
Yeah. Yes. I think that through this collaboration, they became very aware of the power of doing research and creating evidence, and they said, okay, now we have this project ongoing, and it has a lot of promising outcomes, but we actually would like to present to you an important topic that really worries us as clinicians. And that's when they brought to the table the topic of suicide among youth.
Right.
And that's when we started to talk about suicide and looked for funding to do research in suicide.
Right. And how far have you got with that? And because I presume it is less advanced than the work with the women and so on.
Yes. So actually, it started very similar way. We first said, okay, clinicians, the team of clinicians in Zambia, they said, we have a really big problem. There is a social alarm about suicide attempts among youth. There is a lot of interest. The government is saying this is, a new epidemic. We are seeing a lot of youth coming to the emergency room at the hospital with suicide attempts. Let's do something, no? And when I went to the data and looked for National Registry of Suicide Attempts or publications, we found there was very, very little. And so we said, let's create first the evidence, because without evidence, it's very hard to find funding. It's very hard to develop an intervention or justify policy change or intervention development at the authorities if there is no data that supports that this is a problem, actually. And what we did is, after getting some funding, it was to go very systematically to all the healthcare centers in Lusaka and look systematically for the medical records. And we went through more than 30,000 medical records for any kind of indicate of suicide attempt.
Got it.
So we could create a data set of what was the data on suicide attempts among youth. And we looked retrospectively for the last 4 years. So we could also include COVID times and see the progression of it. And we were also interested in clinical patterns. What kind of youth profiles were, more associated with coming with suicide attempts. It was there was a gender association, an age association, an education. So we were interested in seeing what patterns. And what we found is that there were actually very, very little records in the hospital. And it's very, very few the data about suicide attempts or anything related to suicide that it is kept in the hospital. So
is that also a cultural question?
So it's a stigma thing. It's an underreporting that it's pretty global with suicide. But of course, when resources are lower, and there is no systems of surveillance in place, this is much more common.
Of course.
So that's what the first evidence we could bring was that there was an underreporting. And what we did next to that is to complement this data with qualitative data. And basically what qualitative data means is that we went back to the hospital, back to the healthcare workers and the people working at the medical records, archives and registries, and we talked to them for 2 hours with each. So we had 40 interviews with people involved in the suicide management and try to understand what was actually happening.
Right.
And we also interviewed youth who had gone through the experience of having a suicide attempt and receiving services at the public hospitals to get their experience and their information. And that's, the second part of this project. And it was very interesting to see that the data we're saying there has been almost non-suicide attempts in the last 4 years. We found 300 suicide attempts in the last 4 years in 5 different hospitals. But then when we asked the people working at the emergency department, they said, we see at least one every day.
Wow.
So that is the gap that we were able to kind of fill with the qualitative data. And as you can imagine, following the story, now we are creating a training program together with all the people involved in the interviews with the goal of creating a surveillance system that it's agreed upon all the different hospitals that can create a better data collection system that is adapted to their culture, and it's adapted to their way and their healthcare system functioning. And this training will be along with suicide management for prevention, as you can imagine.
Yes.
So it will be combined.
So that you'll be bringing a model of prevention as well, which will make a lot of sense. Yeah. So when you were talking, I was thinking that it was almost like being a detective, looking through the evidence, and kind of bringing it together, and then finally making a program around it, or that first of all research. So your passion for evidence is very clear, isn't it?
Yeah, I think honestly, our profession. We are very fortunate because we are able to bring reality into clinical questions, and that's bringing evidence. Is saying, okay, what is really happening and how can we look at it, and telling stories. I'm a big fan of saying, okay, where is the data? What is happening really? And then after that, what can we do with this data? It's not only about managing data and collecting data and having really nice and fancy data sets. It's about what is this data saying to us and what can we do with this data so it has an impact to the people who are, really living with such condition or suffering from this. So I think it's a detective, it's the passion about research that we are super lucky that we can kind of have a question and we're, we are paid to respond to that question. It's really out of curiosity.
So that brings me back, in a sense, going back in your career, or it brings me at least to Basel, which is where you are now cited, at Swiss TPH, as you called it. How did you get there, and what is it that you do there apart from the work that you've already described to us?
Yeah, so I'm in Basel. I moved here 3 years ago now, and I lead a small group in public mental health. And this is something pretty new for this historic institution. Of course, there has been an initiative and an interest on bringing mental health to their history of research in public health, environmental health, and infectious disease research. But, 3 years ago, I was kind of brought here to start a group in public mental health, and that was an incredible opportunity that I had. I was coming from Boston, from the Massachusetts General Hospital. There is a department of Disparities Research Institute there, or unit, and that is part of the Harvard Medical School. So I was coming from Harvard University, where I was working in similar projects, but instead of working in low-income countries, I was actually working with low-resourced populations living in high-income countries. So I was focusing my research in underserved groups of population in the US, basically. So that's where I got my postdoc and early or junior researcher training, doing research, developing interventions that could improve mental health for migrants, refugees, and underserved populations in the US. And also in this task shifting model, creating training programs for people from the community who could be providing psychotherapy to their community, so that we improve access to good quality of mental health care in every setting, at the community level. Yeah. And that's where I worked basically with Dr. Margarita Alegría at Harvard Medical School, who was my mentor, and I worked with her during many years. And that came from, actually, I arrived to Boston coming from Barcelona, where I'm from, and I studied medicine, and I worked, and then I did my residency as a psychiatrist, and that's how I started my interest in underserved populations, or providing psychotherapy and mental health care to populations that didn't share the same cultural background as I had. And that's
that's so interesting, Irene. Are they? So you're Catalan. You're from Barcelona, yeah.
Yeah.
So those populations that you mentioned when you first started to practice and qualified and so on, were they refugees? Where were they from? Those people?
Yeah, so that started early on when in the residency. I was in a general hospital in the suburbs of Barcelona, and it was, some time ago, and we didn't have refugees. We had migrants, people who were arriving from northern and sub-Saharan Africa. Mm-hmm. And as clinicians and as psychiatrists, we were never trained to be able to treat mental health problems among people who had a very different understanding of what mental health was.
Right.
And that's the first thing that I realized. I'm from Barcelona, but actually I grew up in a very small town with not a lot of social or cultural diversity. Mm-hmm. So for me, it was a big shock to see that we were not only not speaking the same language, but actually we had very different understanding of what well-being was, yes. And it was not shared with the persons that I was trying to support.
Right.
And that was the first challenge that actually kind of lighted my curiosity and willingness to know more, and that brought me to be trained at McGill. There is, a social and cultural psychiatry training program that I really recommend for the ones who are interested. And I was there for some months.
Yeah.
And then I went back to Barcelona and I worked in a clinic that it's targeting or especially offering mental health care for people who has a migrant background or a refugee background. And that's where I started to work with such populations as a clinician.
Because, you know, when, as you know, I've managed organizations which have in the field of global mental health.
Yeah.
And what I have found often is that when the practitioner, the medical practitioner, and the patient are unaligned, in other words, the practitioner has had training in one kind of, let's call it Western medicine or whatever, and the person is from another culture. Sometimes they blame the person from the other culture like it's their fault. And so to be able to overcome that in your early days, and then to go and study at McGill to really try to sort of understand it and get on top of it, must have taken quite a lot of thinking on your part, a lot of thinking through.
Exactly. And that's, you know, we used to talk about cultural competence, and we don't talk about this concept anymore because it's not that you study and then you become culturally competent. This is a continuous, it requires a non-ending learning process.
Yes.
And it's a cultural humility. Now we do trainings in cultural humility. It's how to actually think about yourself, your own prejudice. What do you think is normal?
Yes.
And how this is completely questioned, and it's completely influenced by where you grew up and the education you received and the environment you have been living. So for me, it was a long journey because of the lack of diversity that I'm made out of. And that actually, I think it was also what inspired me to really, you know, make an effort and really push towards that direction and become someone who is very specialized in working with cultures that have nothing to do with my origins.
Sure.
And that's kind of how what moved me. That it was not enough for me. Only doing the clinical part, it felt limited. In my perspective, you can treat one person after the other, and I was looking for a bigger impact, something that would make a change in the community of clinicians, but also at the policy level, that it would have an impact. And that's what made me do a PhD in public health and psychiatry, and access to mental health care for underserved populations. So I couldn't stop, you know, with clinical work or clinical practice. And I moved then to do, you know, the PhD in access to mental health care.
So let me get this right. You started as a doctor, of course, like, you know, like any psychiatrist. Then you became a psychiatrist. Then you went to McGill. And then you went to Harvard. Am I right? To do the...
Yeah, in between, I was working in a transcultural psychiatry unit in Barcelona. And I also practiced in Trinidad and Tobago in the Caribbean for a short amount of time, but I was there for a year and a half.
Wow.
And then after a quick time, and I had 3 children on the way, so I mean, that's also something important too, because it's also part of the career, honestly.
Yes, of course.
Very much important. I don't know if it's part of the professional career, but of course it's part of your journey.
It's part of your life. Yes.
Every of these ones take time, you know, it's a lot. So yes, I did my PhD while I was in Trinidad and Tobago, Barcelona, and then Boston. So I ended up at the Disparities Research Unit at Massachusetts General Hospital, as we said before. doing a postdoc, and then becoming faculty at Harvard Medical School, specialized in cultural humility, task shifting models, and psychosocial intervention, development, and adaptation. So that's kind of the formal training, yes.
Well, it's the formal training, and because you've been kind enough to share it, also your life, in a sense, your life journey with, of course, your 3 children along the way, which is, in other words, starting a family. And you managed to do all of that and achieve the results that you've just described to us a little earlier in Zambia, which sounds amazing, absolutely amazing. I know that people come to you for mentoring from time to time. Is that something that you have noticed as your career has developed?
Yeah, actually, yes, I think it's not an easy journey. Research is a very competitive world, and that's the reality for, it's not easy. Many people come from privileged backgrounds, and it's not easy to be able to work and get a salary at the end of the month out of this kind of work. It's a privilege to be able to work on creating evidence and creating interventions that will have an impact long term, but it's not easy.
No.
And it's not easy for many people. So I think maybe out of my passion on the topic, or also out of the surprise of some people when they heard or they see me also as a mother or as a clinician in the past, and as a person who enjoys other things beyond working, I received some demand on being a mentor or inspiring others on how this can be made, and I enjoy very much in supporting and helping other people to get to what they're aiming for. So yes, that's we have a small mentoring group right now here at the Swiss TPH that it's open to anyone who's willing to have a career in public mental health, and it's online. So we have people from Zambia, of course, people from US, from my journey, from my life journey in the US. We have people from the Netherlands, from Spain. So it's a pretty diverse group of young people who are trying to get their career going in the field of public mental health or global mental health research.
Irene, I have a feeling that we could have had 2 or 3 interviews, or we could have gone for a lot longer, but we are kind of getting to the end of our time now. And I just wanted to ask you a couple of very short questions. First of all, if people wanted to write to you, do you have an email address they could use?
Yes, of course. It's my name, Irene, and then my last name, Falgas Bague. It's very easy to find online.
Sure.
And then at swisstph.ch.
Yeah. Well, we'll make sure that also goes up on the podcast. That's not a problem. Young people, when they're trying to work out what they should do in their lives, I think listening to you, I think they'll be inspired to want to work in one of the fields that you have, if not all of the fields that you have mentioned. And would you encourage young people to do that, or is it a time? Has the time passed when they can do that? What do you think?
No, I think now it's the time. I mean, I think we are in an amazing moment where mental health is kind of on the mouth of everyone. Sadly, because of the circumstances, that it's not always easy, and we have a very complex social context right now globally. Mm-hmm. But it's a moment to dedicate your career and your work to mental health. Mental health is something that requires a lot of science, a lot of research, and also a lot of people doing activism and policy. So I think we are so few people still, and we need good researchers coming from public health, from epidemiology, but also from basic science, and really get all the technology we have been behind for ages. And I think it's now the perfect moment to start a career in mental health for sure.
Great. Well, on that note, which is a very optimistic note,
we can have a downside, but I think it's really important to focus on the positive,
Exactly. Well, I think we want to thank you very much for a really inspiring interview, and we look forward to hearing how the work goes in the future. Thank you very much, Irene.
Thank you. Have a nice day, Chris.
Thank
Bye.
you.